for chairing, and welcome also to members of the public and our fellow governors. So we've got quite a busy agenda today, so in proper Russell fashion we'll try and keep the pace going. So apologies for absence. We have Harkamel and Anne, I think you're going to cover off her bits and pieces, and Russell, who we may see a bit later. There's no other apologies for that we've got, are there, don't there? No, Cecil. Okay, any declarations of interest? No. So is everybody happy that the minutes of the meeting of the 1st of December 2021 is a fair and accurate reflection of the discussions that took place? Okay, that's great. So I'll just scroll down to matters arising, which is page 17. Okay, so matters arising. Okay. So there are two complete actions, which is Miss Rosemary Hyde's declaration of interest has been added to the register, and the green plan has been presented today. Actions in progress then, clinical governance to keep the board appraised of the progress with Coventry and Warwickshire Pathology Services, CWPS networking. Glenn.
Yeah, just a couple of things to update on that. Firstly, it's been confirmed that pathology services are still going to be in a national framework for the first 6 months of next year financially, because of the ongoing demands of COVID. So we won't be reverting back to the kind of pre-COVID arrangements until at least the middle of next year. And also the next big thing that will happen with the network is the formal joining of the network from our colleagues in Hereford and Worcester, which obviously Wye Valley Trust are involved in. So I'll bring back the details of that when they're available. Okay, smashing. Thank you, Glenn.
The next action point is the acting chief operating officer to ensure their respective section was clearer for easier understanding. Anne, I think he just says this has been noted. You know, it's actually been done. It's been done. Okay.
Yes, it's been done. Thank you.
Super. Okay, next action point is the chief nursing officer and chief people officer briefs the chairman on the monthly usage of bank and agency hours, comparing this to how many whole-time equivalent staff are rostered. Fiona and Gertie.
Fiona, you're on mute.
Apologies.
Right.
Okay. I have updated the chairman outside of the board in terms of the split between agency and bank usage. We generally have about a 20% gap in fill rate for temporary workers, but the split between agency and bank is about 83%. Sorry. 90% of our temporary workforce is filled with bank, and approximately 7 to 10% is filled with agency. I haven't got that as whole-time equivalent, which is the specific question he had, so I have got to still work on that.
Okay, thank you, Fiona. That's great. And then the final action in progress, which comes from Clinical Governance Committee report. Glenn, this is to ensure the concerns of the Clinical Governance Committee be raised at the next provider collaborative meeting concerning staffing pressures in the domiciliary care and care homes area. Glenn.
Yeah, we had, as reported there, we had quite a big discussion about that, and it's something that we will also cover off when I talk about our objectives later, because this is going to be a big HR issue to resolve.
Okay, super. Thank you very much indeed. Okay, so let's press on. Glenn, the next is the appointment of...
Sorry, Simon, I think Anne's got an update on the Black Swan event training. It's at the bottom of that page. Thank you.
Thank you, Sarah. Thank you, Simon. Yes, we had our training this morning for board as part of board workshop on risk appetite. The risk management strategy will be launched at April's board of directors. And then it is planned, and we are just scheduling the training to take place during May to really link our training to the refresh of the risk management strategy and the new board assurance framework and risk appetite. So really making sure that is part of our implementation of the risk management strategy. So that will be scheduled for May 2022, and we'll pick up Black Swan training as part of that.
Super, Anne, thank you very much indeed. Okay then, so Glenn, the next item is the appointment of the vice chair, which you're picking up in Russell's absence.
Thank you, Chair. So this first item is a Council of Governors decision, but it's in consultation with the board. So following Bruce Paxton's term of office ending, we obviously do need to identify a vice chair, and the recommendation has gone to the next meeting of the Council of Governors that should be Simon Page. So they meet on the 10th of February to consider that. The board is asked to consider that recommendation. So I'm just going to see if there's any hands up of any issues on that before we move on to the next item. And there aren't, so I'll assume we're all comfortable with that going forward to Council of Governors.
But I can carry on chairing in that case. Okay, and Glenn, the next item then, which you're also picking up in Russell's absence, is the recommendation for the Senior Independent Director.
Yes, the subtlety of this appointment is that it is a board appointment in consultation with the Council of Governors, and obviously this Senior Independent Director role was carried out by yourself, Simon, up until now, and with your appointment as Vice Chair, we should identify an alternative, and Sue has expressed a willingness to do that role. So the proposal here is that Sue Whelan-Tracy takes on that Senior Independent Director role. So I'm looking round to see if there are any hands in opposition to that. Otherwise, I will assume there is full support for Sue taking on that role. So thank you, Sue. Back to you, Simon.
Thank you, Glenn. Good luck, Sue. So we move on to agenda item 5.3, which is the annual review of the review. I'll get this right in English in a minute. The review of policy review group terms of reference. Anne.
Yes, it is a tongue twister, that. The changes to the terms of reference that are proposed here are really the changes to job titles. So reflecting the move to chief roles, and also a change from the assurance manager to the assurance and quality manager. And a change as well, just in terms of the deputising in the event that the managing director is not available.
Okay, Anne, thank you very much for that. Has anybody got any questions or observations regarding the terms of reference? Okay, thanks very much. So let's move on then. And the next agenda item, 5.4, is the Green Plan. And for members of the public and the governors, this was discussed in some detail this morning by the members of the board at the board workshop. So Sophie, perhaps you'd give a précis of what it's about and what we're trying to achieve.
Yeah, absolutely. Thanks, Simon. So towards the end of last year, the NHS guidance was issued to update on organisations moving towards net zero by 2040. Board will remember a few years ago we brought our sustainability strategy here. This is an updated version now, taking into account all of the recent guidance and all of the things that we as an organisation need to consider. There's some really tight timescales actually to turn this report around. So I firstly just want to start by saying a huge thanks to Chris Collegia and all the leads that are identified in this report, because there was a considerable amount of work done in a very short space of time to put our organisation in a really good position to respond to that guidance and not just continue with our sustainability strategy from previous for another year. I think importantly, this is a huge area of focus for us as an organisation, but also for our partners and the system. And actually, through that partnership working, we should be able to achieve a lot more together. The paper sets out, the Green Plan sets out our response to all of the areas that are identified in the guidance that we need to respond to. the conversations we've had as a board is actually where are those big areas that we can focus to make the biggest difference. The main project for us as an organisation will be the procurement exercise we're doing around a total energy solution for our estates, and our estates is one of the biggest things within our control. So Chris is leading a piece of work based on the process that Y Valley have done in the group to put us in a really good place to be able to apply for funding to support the implementation of this green plan. And I suppose a risk around this green plan and the ambition that we've set out as a board is that affordability on some of our estates as some of our estates plans. In the private board today, we'll consider and discuss the estate strategy, and that will come back to public board next month. But just to give that assurance that this will absolutely need to align to our estate strategy and is a fundamental part of how we'll renew that. So happy to take any questions on this, but hopefully it sets out our ambition as an organisation. And we discussed this morning about making sure we continue to develop and evolve this plan as new technologies, new ideas come through from our teams and from the government as well on some of this.
Okay, Sophie, thank you very much. Glenn.
Yeah, very supportive of this, Sophie. Thank you for the document and for the work you put into it and your team. As we discussed earlier, I think it's so important that this is top of our agenda moving forward as an organisation for lots of reasons. And it's a bit of an unusual scenario that we're setting out an ambitious target for the future, and we're not entirely sure how we're going to get there. And I think this will evolve over the next few years, but it's really important this stays on the top of our agenda and we keep looking at the innovations and opportunities that come along to allow us to achieve that milestone.
Thank you, Glenn. Totally agree. Any more observations and questions? I can't see any hands up at the moment. Okay, so for members of the pub, Sophie, please.
I was just to add to that, I absolutely agree. And one of the things we've discussed is obviously at the moment, Sue, as a non-exec, sits on our sustainability strategy, and we will make sure that there's a lot of, we continue to bring this back to board for discussion around how we're evolving it and how we're reaching our ambitious targets over the next, well, I don't know whether the whole of the 20 years, but certainly in the next 5 to 10 years.
Okay, Sophie, thank you very much for that. So for members of the public and governors, this was universally endorsed by the board this morning when we discussed the matter. So let's press on and move on to agenda item 6.1. Glenn, the Chief Exec's report.
Thank you, Chair. So it's been a couple of months since we met in public. So unsurprisingly, there's been a lot of policy and guidance that has come out since then, and we've had that time of year where we get the annual planning guidance, and predictably Christmas Eve we received that document, and there were no great surprises in there. The 10 priorities, I think many have commented that that's a lot of priorities for the NHS to have, but when you work through the detail, it's really quite hard to remove any from that list of priorities. And we will be discussing later our objectives for the coming year, and they're very consistent with that list of priorities. It also set out some of the expectations around the way we're going to reshape the NHS, particularly through some increases in beds, but more importantly, some increases in virtual wards and working in a different way to reduce hospitalisation of patients, and that was well set out in the strategy. It also updates some of the indicators around urgent care and the expectations around urgent care, and identifies a new elective recovery fund. We are expecting an elective recovery strategy to be published any day now, which will set out for the next 3 years how the NHS is going to recover waiting lists following the impact of COVID. We're in a really strong position as an organisation with a low level of long waits, and therefore we will probably position ourselves as an organisation offering mutual aid to other organisations, and around us there are some longer waiting times, and we've got a very productive range of elective specialties. In fact, we might well be showcased on this nationally with some of our track record on not cancelling patients. Lots of detail on allocations and funding, and I know Kim will take the board through a bit more detail of that maybe next month. There's some new standard contract terms, and these for the first time start to move away from some of those NHS constitutional standards with, for example, the removal of the zero tolerance for 52-week waits, which is really in recognition of the fact that we have currently across the NHS quite a high number of 104-week waits as a result of COVID. So a realistic set of new targets. I then refer to the National Discharge Task Force, which has been meeting since the start of December. And that task force has set out an ambition to reduce the number of patients who are in acute beds, whose acute episode is over and they're waiting for either to go home or for care packages. And indeed, within those numbers, there's a high number of patients who are stranded in acute beds who the acute provider themselves could be doing better to get home. So a lot of the focus in these first few weeks of the National Discharge Task Force has been to look at those patients and some helpful guidance and focus on the numbers as certainly we may comment later has shifted our numbers a little bit more positively on that. There will be a small number of trusts nationally who will get some targeted support because they have particularly poor performance and long waits on this indicator, and I don't think those are published yet, but I can confirm that we're not on that list and not close to that list. The COVID update, I refer to an improving position with COVID, despite still quite high numbers of hospital cases of COVID. A large proportion of those, though, are patients who have been tested on admission and found to have COVID, but who are not symptomatic with COVID. They're here for other reasons, and what's also even more encouraging is smaller numbers of patients on oxygen or in critical care. So we are hopeful that that's a trend that will continue. The other thing that I need to update on since this board paper was produced is obviously a change this week to the approach to mandatory vaccination of health and care staff. This was an incredibly onerous exercise for all NHS providers, and particularly for Gertie and her team, trying to identify whether people had or hadn't been vaccinated and then support people to be vaccinated, and then preparing to dismiss members of staff who wouldn't take up the vaccine. On Monday, the government decided that they would not progress that, and they've entered into a new consultation on what we should do in response to obviously a changing picture in COVID in the way I've described, but we will still absolutely be encouraging our staff to be vaccinated, regardless of whether it's mandatory or otherwise. Really good stats there on ambulance delays and ambulance handovers, which I won't go through because the chart says it all. I then refer to getting it right first time. I apologise, there's a lot in here, but there's things I wanted to bring out. But getting it right first time analysis is something that we need to focus on more as a board, and we will focus on this a little bit more when we look at our three trusts in the group coming together in a parallel board meeting later in the year. Some good data there which shows both elective and non-elective performance, with SWFT being described as an exemplar performer in the way that we protect our elective capacity and ensure that despite the busy DGH that is Warwick Hospital, that we still cancelled very, very few elective cases and maintained elective throughput throughout COVID. The only time we stopped actually was when we were told to nationally, and that's why our patients are not waiting as long as they are in other parts of the country. And we will build on that strength in our submission to try and get a bit more capacity to offer mutual aid to other organisations. And then some detail about our integrated single point of contact team and some really encouraging stats again in another chart there, looking at their response time improvements. That's all I wanted to go through. I know I went through quite a bit, but it's all good stuff, Chairman. I hope you agree.
I do indeed. Thank you, Glenn. That was very comprehensive, very easy to agree. Any observations or questions for Glenn? Oh, I can't see whose hand. Rosemary.
Yes, hi Glenn. One point you talked about in the paper was about the rollout of smart technologies for patients to be treated at or to be observed at home to keep them out of hospital. And obviously this is a really important move to help that. How far have we moved on this? Is it still at a pilot stage, or have we or will we be properly rolling it out? And is it currently just in nursing homes, or is it in people's private homes?
So there's several different bits of technology, and so I'll try and give you a short answer on this. But we've had quite an extensive rollout across Warwickshire. If you take the Dockerbo system, which is an app-based technology that supports individuals in care homes and provides ongoing monitoring of those individuals, and actually we produced data which has been reported nationally, which shows a reduction in hospitalisation. That's across all care homes in Warwickshire North and quite a number in South Warwickshire. So the rollout now will be to cover all care homes in South Warwickshire, which we are resourced to do and we will move forward on. There's another technology called MySense, which is about individuals in their own homes. There's an element of Dockerbo also, which is about supporting the discharge of patients with long-term conditions. And we're trialling that now around our respiratory patients. So some of this is about trials. A lot of it's going, well, all of this is going through the digital hub in Stratford. So we're evaluating the benefits of this technology and then going for greater rollout. We've probably accelerated that more than I would have suggested we would have done, because there's been additional money available to do that, linked to COVID and linked to the discharge task force. So we're taking every opportunity we can to get those resources in to roll that out. And we're also looking now at Hereford and Worcester coming alongside us with the monitoring of the Dockerbo work particularly. They're either going to implement our best practice in Hereford and Worcester, or we're going to support them from Warwickshire to do that. So so a lot going on. Probably something actually we ought to spend a bit of workshop time on again soon, having another look at.
I think that would be a good idea, Glenn. Yes. So yeah, thank you very much for that.
Really helpful.
Rosemary. Yep. Okay. Thank you, Rosemary, too. So if there are no more questions of Glenn, we'll press on and talk about the integrated performance dashboard and Anne, the managing director's commentary, if you'd like to start us off.
Thank you, Chair. And as part of this introduction to the integrated performance dashboard, I really just want to acknowledge the hard work and commitment of staff in the delivery of improved performance measures across a number of quality and operational metrics. And this happened at a time of challenge. As the period we're reporting on, we really faced that unknown impact of Omicron. So I'll hand over to colleagues to go through the detail, and as you've referenced, Chair, I will provide more information as part of the CW update on the operational metrics. Super, thank you, Anne, very much. Before we move on to Fiona and the nursing report then, is there any questions or observations for Anne? No, okay. Fiona, perhaps you'll talk to us about your Chief Nursing Officer report, please. Thank you. I really have got the wrong teeth in today.
Thank you. Just wanted to pull out some good news, and that's around the friends and family test. As you know, we've been struggling to get patients and the public to fill those cards and that give us feedback on FFT, but our rates have improved recently with some additional support to the clinical teams. We are still intending to roll out the text messaging system to improve ED, which is still a bit stubbornly low there. I just wanted to assure the public that in terms of learning from incidents, falls, incident errors and others, we always do an investigation, and I've identified a number of areas of action that we have taken to mitigate the risk of future incidents happening, and some of those are cited in my paper. But the areas that are continued work needed is particularly around the CAMHS patients. You'll see from the graphs in my report that the children in crisis with mental health crisis attending Warwick has gone up recently. That is an expected rise post summer holiday and Christmas holiday, and actually now that we have more data on those children, we can see that as a trend and is predictable. So we have asked our mental health colleagues to shore up their business continuity plans to ensure that they have additional resource for those expected trends. And lastly, just wanted to reassure the public, because it's very different for us to be reporting mixed sex accommodation breaches. That is something that we hold very firm as a line, that male and female patients or different gender patients aren't put in the same bay together when they're in an inpatient facility. We have had to make some difficult decisions through the pandemic and in the most recent wave as well, and balancing the risk of separating patients from an infection prevention point of view or a gender point of view. We have taken the lesser risk in terms of mixing gender together. Obviously, that comes with mitigation of explaining that to the patient and their relatives, of drawing curtains and keeping privacy and dignity maintained at all times. But it is effectively a breach, so we have had to do that. But that is not an expected trend to go on.
Fiona, thank you very much indeed.
Okay.
Any observations or questions for Fiona? Rosemary.
Thanks, Fiona. You talked about the SIs, but I see there were 2 never events over the last couple of months.
Yeah.
I wonder if you could just explain what they related to and what we're doing about that.
Yes, we had another event in relation to a guide wire, and we've investigated that, and it's come through clinical governance, and there is some learning, but actually, but it came down to human error. It was a type of equipment that was unfamiliar to a new member of staff, and they thought that they'd taken the guide wire out from inserting a truss drain, and actually they've taken what we call a stiffener out, which is a piece of the equipment, not the whole of it. And so it was human error. They've reflected on it. We've now included more detail in terms of the different types of equipment we have in the ICU in their induction. We were confident that the individual member of staff felt confident, wasn't rushed, thought he knew what he was doing, and so it wasn't a time constraint or a staffing constraint. You know, we've had a picture around the pressures in ICU recently, but that didn't reflect in this incident. It was purely human error. He thought he knew what he was doing, but made that error. Interestingly, the patient did have to have a surgical procedure to remove the guide wire, but is now fully recovered. The other was a wrong implant, and that was a patient going through a knee replacement where there is a judgment call to be made about 2 different types of insert and the size of them, particularly of a joint replacement. And they had 2 different sizes, and the intended size was not the one that went in. Again, no harm to the patient. They decided to leave them in there. It wasn't going to affect mobility or long-term outcome of that patient. And obviously, a duty of candour was applied, and the patient was happy with the outcome. But officially, we hadn't agreed to put that particular implant in, even though it didn't make a difference. So we did declare it as a never event. But again, no harm to the patient.
And thank you, Fiona, for being so open about those. Thank you.
Yeah, indeed. Thank you very much, Fiona. Dave Spraggett, please.
Well, good to see the Friends and Family responses the positives getting up. I was just interested to see that, of course, the number of actual responses made in community was considerably higher than most of the other departments. I mean, by a enormous margin. I just wonder if the other areas could learn from community, and what could they learn from community for how they managed to get their response rates so high.
It is, yeah, so it is a very different methodology, and if I briefly explain the difference. So the district nurses have patients on their caseload, as you know, for years and years and years, and so there is a struggle between repeatedly asking do they recommend the service and not. So then it's always new patients in the hospital because it's new patients every week. So the district nurses tend to choose one day in a month where they go out to every patient that they see, they hand the card over and they ask for feedback, whereas it's a continuous drip feed with new patients in the hospital. I think possibly sitting in a patient's home giving a card influences that that result.
Okay.
So there may be some bias there in terms of the fill rate, but also the feedback, but that's the methodology that has fitted practically into that service. Also, obviously, patients in the hospital are more sick, so they may be less able to give feedback at that particular time. So very different populations, David.
Yeah, it's just that, you know, the numbers make a big difference to how valid the actual answers are. And if you get a lot of high, you know, good answers from a lot of people, that says a lot, doesn't it? I mean, yeah, the other question is quite different. It relates to the Caesar rate that we're getting, and we're consistently higher than the national intended rate for Caesars in there, and we have been for a very long time, haven't we? We're near 20. We're nearly 20%. And I was just wondering.
Caesars, sorry,
the Caesars. Sorry, yeah, the cesarean section rate.
Okay.
Right. Yeah. Sorry, Caesars. Yeah. And I was just wondering, are we doing anything active to deal with that? Because it seems to be a consistent. This isn't just a 1 month problem. This has been 1, 2, 3 years. It's always been high. And it isn't because our mothers are higher risk mothers, are they?
No. So, David, happy to give the detail of the ongoing audit into clinical governance, because you probably haven't seen it since you've been there. We've done a deep dive regularly, and they on an ongoing basis audit whether we could have prevented that. I think I would argue that there is a balance between the safety of the mother and the baby, and sometimes actually C-section being the best, and so the best solution. Saving babies' lives have actually encouraged that in some ways. But we have got a percentage of women that choose to have cesareans, which is higher than some of our population, and they electively choose that. But for the emergencies, I think there's the ongoing theme, and we have had different themes in previous times, is that the saving babies' lives is actually encouraging that increased growth.
David,
I'll take that clinical governance letter to another time. Okay.
That's what I was going to say, David. I think it's exactly the type of subject to do a bit of a deep dive, because we know our Caesar percentage has been high for a number of years, and we've looked at it at different points and assured ourselves, but it's always good to have a fresh pair of eyes. Now, Charles, I did see your hand go up. Did you want to add to that debate, or are you happy to move on?
Fiona had just made the point I was going to make, so I put my hand down.
Okay, thank you. Apologies, ladies and gentlemen, that I arrived a bit late to today's meeting. Simon, thank you very much for chairing in my absence. So I think we're up to Harkemell's report in the pack. Harkemell being on holiday. And which key points would you care to pull out of Harkemell's report, please?
Yeah, thank you, Chair. The key points are really around our A&E December performance. We improved our position from 41st to 20th. which is an excellent achievement. We did have lower attendances, but there was a similar conversion rate to the previous month. And as Glenn has reported, the ambulance attendants were higher, but the handover delays were lower. We had, over this period, better flow across the organisation, and as a consequence, that improved assessment turnaround time. COVID did present us with a challenge. There were several wards and bay closures, and we did see an increase in arrival of asymptomatic admissions. On stranded, we're reporting up to, for this period, our 21-day standard remains lower than pre-pandemic. There was a lot of focus on discharges in this period. There was a 12-day of Christmas comms initiative to raise awareness of discharge services available, and there was a MAID event planned just before Christmas. Glenn in his report referenced the real focus nationally around discharges and addressing the delays for medically fit for discharge patients. On the end of January, we had 34 patients waiting to exit our acute beds. 12 of those were in our community hospital beds. And there's been such a focus underway internally on discharges. And we're now in a much better position in terms of the confidence of our data. We're getting those daily updates. And as of today, we know we've got 57 patients, 34 are waiting pathway 0. So those are our simple discharges. Pathway 1 are requiring some of that additional support in their own home, in which we've 19 people waiting. 3 for pathway 2, which is requiring ongoing rehabilitation, and pathway 3, 1 person's waiting. So a lot of focus, a lot better understanding of the data, which can only help our continued improvement on this work. RTT, that decline is expected in month, but nonetheless focus remains on reducing the volume of patients waiting over a year, and there's an action plan in place to reduce this to 0 by the end of March, and that work is on track. And we had 31 currently that could be 104-week breaches, and compared with 54 last week. So that gives a sense of the work that's underway. Diagnostics, we've seen a large increase in the volume of patients waiting for diagnostic, and the waiting list is much bigger than it was pre-pandemic. Having said that, as you will see in the report, 97.17% of patients were seen within those 6 weeks. Cancer performance didn't hit the performance standards, but nonetheless performance remains stable. And of course, the focus is on the 28-day standard, which comes into effect in April. And on our elective restoration, Glenn has mentioned that our strong performance there, and that's particularly remarkable against the backdrop of the operational performance and the period in which we were operating. The admitted stops were 101% of their 2019 levels. So, so happy to take any questions on the points made.
And you could make a great chief operating officer with that type of summary of the performance. Thank you, Anne. Questions or perspectives to Anne on Harkenwell's behalf? Rosemary?
Hi, I just wanted to come back on the cancer, the faster diagnosis challenges. And am I correct in reading into this, the comments that you make that UHCW is ahead of us on this, but both George Eliot and ourselves are behind? Do we need to be having? Well, sorry. First of all, is this down to our individual controls over the trusts, or is this about links to tertiary providers? And if so, are there systems discussions going on at the moment to try to move this forward to improve the position for the DGHs?
Yes, there is a lot of work underway, and for us, it's really our 3 large services in terms of referral numbers that are struggling around the 28-day fast diagnostic target: colorectal, gynae, and urology. And so we are working around the process of that pathway redesign in collaboration with colleagues in the system, but also within primary care. And there has been investment in those pathways from both the trust and the system. So there is degree of confidence that once we've embedded the pathway changes, that we will be in a stronger position around our overall performance around the 28-day faster diagnostic target.
But at its simplest, going back to Rosemary's point, are we a victim of issues elsewhere in the system, or because of the way the pathway works, or is it down to us?
I think it's probably a mix. We're noticing, and Charles referenced this yesterday, the referrals coming through, perhaps from primary care, that are resulting in an increase in the referral numbers, and that is having an impact on the overall trust performance. So it is a combination of us, the access to diagnostics and the referral pathway. So it is a combination of those factors.
Okay, Charles, do you want to add anything to that, please?
Yes, I mean, part of the cancer strategy is to encourage more diagnosis of cancer and earlier, so you're going to get more referrals. And the problem is actually really getting the diagnostics done. So I think our biggest effort is around those diagnostic pathways in terms of access to radiology and some of the other tests. And that's where the effort is. And that's where we will reap the rewards in terms of the 28-day standard. But this isn't really a UHGW problem, going back to the original question. It is something that is really with us and primary care's remit.
Okay, so in summary, we need to do better. Glenn?
Yeah, I was just picking up Charles's point there. And actually, one of the real success factors has been the level of diagnostic activity that we've been able to recover. And some of that's because we've got the additional mobile scanner over at Stratford as well. So what we've got to ensure, though, is that resulting cases that we identify from that, we can then move forward for treatment. But there's certainly very high volumes of diagnostic activity being done by this organisation, and that obviously has consequences for their ongoing pathways.
Yeah, no, understood. And keeping things going, Sue?
Yes, thanks. Mine was on the same point, just that it would be good to understand a forward view on the 28-day diagnostic. I know the team's been looking with informatics at modelling, and so I'd be welcome that backup workshop or wherever's appropriate. Thank you.
Okay, I can't see any other hands up. I assume yours is a legacy hand, Charles. I'm not sure if you touched on it earlier, Simon, but we had a very interesting staff story from our ICU colleagues this morning, just talking about the phenomenal efforts they have and continue to put into looking after patients who are seriously ill. Members of the public should be aware how proud we are as a board of the phenomenal efforts of all of our frontline teams, but the ICU staff are very much at that front line of managing the challenges that we've had over COVID. Are colleagues happy to move on? Okay, thank you. So Gertie, what would you like to pull out of your report, please?
Thank you, Chair. I'll try and be brief. Some progress with recruitment. Obviously, we've highlighted that clinical support worker recruitment remains a concern. We are working across the system to develop an approach to this, and I will update in future boards on the progress to that. I think would be helpful also to give some reassurance to the board that there are a number of CSWs who are going through recruitment at the moment and had originally been identified to start on the week of the 17th of December. A number of which asked if they could start in early January. So we will see an improving picture around the CSW recruitment, notwithstanding that there's still quite a challenge in that area. Sickness has remained high, but we have seen a reduction since December. Again, I appreciate this is outside of the reporting of this, but it's worth adding in that we saw a high increase with Omicron in December and into January. We have now plateaued. I'll briefly touch on appraisal, where we do need to do quite a bit of work, and that is being carried through the finance and performance executive meeting, where the directorates and the divisions are pulling together trajectories to come back on track. Likewise, with CSTF, whilst we have a reasonably positive position, we are working in those areas where the medical and dental and healthcare science are under. But again, that's being managed through the FP. So happy to take any questions.
Thanks, Kurt. Just before we go to questions, can you just talk about the situation on double vaccinations? Because I'm conscious of the phenomenal efforts that your team have put in and the stresses it has caused with some of our colleagues. Do you want to take that point, Glenn? I saw your hand.
Just to let you know, so I did cover it off earlier in my Chief Exec's report in terms of the latest policy position and the fact that we are continuing to encourage our staff to be vaccinated.
Okay, great. But I would like to put on record, Gertie, my thanks to all of the HR team, because I know this has been a phenomenal push from you guys. Any other questions or perspectives to Gertie? Glenn?
Yeah, I was just going to come back on the sickness position, and as Gertie says, it's high for us, but I think the reassurance I would give is that I see a regular daily update on this and a regional update once a week. The sickness levels at SWFT have been the lowest in the region throughout COVID. So obviously there have been a number of members of staff that have had to isolate that are within those numbers, but our general sickness out with COVID has been incredibly low. So kind of really dedicated workforce coming in and making sure that we keep everyone safe. So it's to everyone's credit that we've kept them so low.
Thank you. Any other questions to Gertie? Okay, so I think we are over to you then, please, Kim.
Thank you, Chair. So the report for the month 9 position is a small surplus for the year-to-date position. Just reassure the board and the public that we are on target to deliver a break-even position as planned. Draw attention really, I suppose, to the CIP reporting. There are some presentation issues where I need to draw out a bit more around the recognition really of how we're closing the CIP gap, where we've got some need to recognise some of the non-recurrent income benefits that we've managed to secure in the year. That has also helped our CIP position. That's also supported really by our productivity efficiency charts that you'll see as well, which demonstrates that we as an organisation are still productive despite the challenges really that we're facing operationally. So that's all positive. Just wanted to draw out really a key thing on the balance sheet. Our cash position remains strong, about 32 million, but we have moved into a net current liability position. That's really reflective of the fact that this is the first month where we have shown the transaction of the sale of our IT assets to the Innovate Healthcare Services. And that's basically moved the transaction, recognised the investment into Innovate, which is funded effectively by a loan from SWFT to Innovate Healthcare. The impact of that is obviously is around our liquidity. We just need to keep an eye on our liquidity. Options around managing that is around obviously making sure that we secure as much sort of capital funding next year from national funds where possible, but also to ensure that we are in a position to deliver surpluses for next year as well. Glenn's alluded to the planning guidance. We need to submit a draft plan at the middle of March. And then a final submission at the end of April. We've had the initial system allocations. Team are just working through that with the system to ensure that we get the right appropriate fair shares for our organisation. We are waiting for guidance around the elective recovery fund. So we need to, once we get that, then we can model through what that means for us so that we can bring back a plan for the board. The plan would be to bring something back to next month's board, either a workshop or confidential, so that I can brief you on to what the implications are for us as an organisation. Happy to take questions.
Thank you, Kim. Any questions or perspectives to Kim? Glenn?
So as Kim said, I think there's a way of presenting our non-recurrent cost improvement programme alongside the recurrent elements. There's a big proportion in all trusts at the moment of almost recurrent, non-recurrent CIP. So I think we just need to show that, just to reassure the public that we're operating within the resources that have been allocated to us. As Kim says, though, I think looking ahead, we're going to get back into some sort of normality around the way the NHS manages its finances, and systems like ours that are in deficit overall due to other organisations have been given a more challenging recovery target. And it's important for us to negotiate how that is handled within our integrated care system. Obviously, we're historically one of the most cost-effective organisations in the NHS, and so to be given the same recovery target as organisations who have large deficits wouldn't be the right way to handle this. So that's something that probably you and I, Chairman, will have to discuss with our integrated care board shadow colleagues at some point soon.
Yeah, no, just to build on that point, Glenn, it is an abject nonsense if the most productive of organisations is penalised for it being so productive. That would be an abject nonsense way to organise the system finances, and I'm sure both you and I will be making that point. Any other questions or perspectives to Kim? Kim, on a partly related point, how often can we assess our reference costs? Is it something we can only do annually or quarterly or 6 monthly or monthly?
It's done annually, but there is a move to make it more frequently on a quarterly basis. So we are one of the trusts who are working towards that as a plan. So my intention is for us to have something more on a quarterly basis.
Super, that's fantastic, Kim, because I really do want to raise the profile, both for us as a board and as for members of the public, about our reference costs. Just for those of us who are unfamiliar with the terminology, if the reference cost is a way of calculating how your actual costs compare with what one would expect from an organisation of your size with the makeup of services and population, what one would expect your costs to be. Historically, SWFT has almost always been below the average, i.e. very cost efficient. And I just want to start to emphasise that more and more in our communications, both internally and externally, so that we challenge all of our sister organisations in the system to achieve. The last time we did the reference cost calculation, Kim, can you remember what it was?
I think it's 97.
Okay, so I think it's 96, 97. Just for members of the public to be aware, George Eliot is around 100, I think, Glenn, and I think UHCW are at about 104. But clearly our challenge is to get that 97 even lower to make ourselves even more cost efficient. Any other questions or perspectives to Kim? Thank you, Kim. Charles, is there anything on the mortality reviews you'd want to pull out?
No, I think just to say that the mortality indicators remain under control, and the medical examiner for death function is working well. Just it's always worth remembering this is very much a rear view mirror indicator. It takes a long time for the data to come through, so we haven't seen the the figures for the very tricky months we've just had. And my colleague Dr. Garcia is actually here for the 6 months report on learning from deaths, which will go into this a bit more later on.
Okay, super. Thank you, Charles. Any questions to Charles on mortality? Okay, thank you, Charles. So Fiona, I think we're back with you on the safe staffing report. What would you like to put?
Yeah, thank you, Chair. So this is a fairly consistent position actually over the last couple of months compared to previous. Our gap does vary, but at worst it's 5 or 6% gap between plan numbers and actual. The report goes into a number of hotspots in terms of vacancies, maternity leave and sickness, and how that reflects into the staffing position. and also some commentary about an increased demand, particularly around mental health patients, not only children in mental health crisis, but in the last month or two, we've now seen an uptick in adults with mental health concerns presenting and staying for lengthy periods of time in Warwick Hospital, which is causing an increased demand for staffing. I think the other thing that I would reflect on, having gone through a number of staffing reports recently, is our need to improve operational planning. So a big percentage of our temporary workforce recently has been on new services that have opened up, or winter or holiday period cover. So I think I've talked to Harkamal and Anne about how we probably need a better strategy in terms of forward thinking those to avoid high cost agency usage. It's in the same way as I was saying about CWPT having a predictable trend, we also do, and we probably just need to be better at thinking through our strategy of how we manage summer holiday, winter holiday, and opening new services with skeleton staff. But that's so there is some risk involved in that, but generally the paper is an assuring picture that we know where our risks are and we're managing the best we can.
Thank you, Fiona. Any questions or perspectives to Fiona? Sue?
Hi Fiona, on operational planning, I recall you updated the board that in maternity there was a piece of work being done that I think was due to report in February around workforce levels. Is that on track? And also I just wondered about clinical support workers, because there does seem to have been a uptick in them leaving, and whether there's a new strategy trust-wide for that.
Yeah, there is. I can answer both of those. Thank you, Sue. So in terms of maternity, yes, that is on track. I'm due to meet with the Associate Head of Midwifery in the next week or so with a almost completed draft, or she thinks it's completed. I need to still see it, and then it will be shared with executive colleagues, obviously, in terms of what that ask is and the affordability of it. I think the ask for the maternity senior team was to work with Sophie's team on on looking at the increased demand for maternity services with the local housing developments and etc. And so almost have a 5-year plan in terms of the workforce capacity that is needed to meet that demand. So there will be some financial implications of that, and we will have to go through the normal planning and management board processes that we do around how we afford that and what the risks are. What was your second question? CWs, yes. So the step change that we've taken to date, Gertie can probably help me with this, is the CSW Apprenticeship Schemes. So bringing them in as with no care experience on an apprenticeship levy, so learning at the same time as developing their care experience in practice. So we've had some national money for that, and we are currently out to recruit for that. So that's the sort of step change. We have seen a increase in leavers and less people being interested in caring careers, and so Gertie and my own team are working on, you know, making that an attractive offer, and either doing that through direct entry and apprenticeships, or just marketing that career progression that they do have, which maybe we just need to refresh, because they have got a good career progression now and could start as a CSW and get right through to, like I am, a director of nursing. I started in the CSW, and I don't think we kind of market that well enough. So that's our intention.
Just for clarity, because I've heard it elsewhere, is there any evidence, Gertie, that some of the CSWs we've lost were people who didn't want to get vaccinated?
We did have a number of CSWs declare their interest not to have a vaccine, but they are still with us, Russell, because obviously it would have been tomorrow that the cut-off date was for that. So I'm not aware that we've lost any significant numbers in the period up to December around this. Clearly, that was something that did affect social care and dom care, but hadn't hit us just yet.
Okay, great. Just one question for me, then we'll move on, Fiona. We referred to children in crisis and CWPT. Do we identify how much additional costs we're having to put in to support children in crisis? And then do we tell CWPT about the additional costs we're having to incur? And then do we ask CWPT to give us the money back?
So Kim can possibly help me with this, but my my understanding is yes, the financial team do analyse the costs both for adult mental health and special costs and children, and we have shared those costs with our partner agencies. Just for clarity, it's not always CWPT, so some of these are social care and psychological support that they need through social care packages, rather than just you know, either spec-com for tier 4 beds or mental health in its truest form. So we share that with all of our partners.
And do we ask for the money back, Kim? We don't. Okay, I see you nodding. Okay, great, thank you. So colleagues, happy to move on? I think we're still with you, Fiona, on patient experience.
Oh, yeah, sorry. Ready? Yes, so patient experience report. I think this is a really positive report. We add a little bit more in each time based on some of the board and public feedback. So, you know, generally across South Warwickshire, we're really proud to have a good level of patient experience and low levels of formal complaints, with concerns being managed locally and resolution found. As I've already said, the FFT rates have improved this time, and we're continuing to work on that. There is some information in the report this time which is new around the patient portal and how the patients and public are really supportive of the patient forum, patient portal in terms of empowering them to manage their own health. And the other pilot that I want to just pull out of this report, and it reflects some of David's commentary earlier in terms of FFT hasn't always worked for us as a way of gaining patient and public feedback, and so we wanted to try something a little bit more innovative, and we've held our first public patient engagement session where we invited a member of the public that had raised a complaint to come and talk to the team involved and give them their patient story, whilst the team weren't allowed to say anything. They just had to listen, and then they've gone away and done an action plan. We videoed that so that we can share it with other teams as well. We hoped that, well, we know that that was a good experience for the patient and family concerned, and it was you know, more hard-hitting and impactful for the team actually listening to it. So we're going to roll that out as a method of just triangulating our data and improving that feedback. That's something that we're proud of. Happy to take questions.
That sounds like a really great initiative, Fiona, and really sort of supports our whole focus as a board on a relentless pursuit of excellence and not resting on our laurels. Any questions or perspectives to Fiona on the patient experience report? Okay, we then canter into the potentially dry but very important subject of the capital programme quarterly updates. Sophie?
Well, I think it's quite exciting, seeing as the car park looks to be open on Valentine's Day. So we're finally opening our multi-storey car park, and board will have been aware of how long awaited that has been. And that will really support us as an organisation with our workforce. It's one of the key things that our staff complain about. So that's a real positive. Hopefully this paper is quite assuring for board around the spend this year. So we're at about 15 million now. So we're on track with the capital programme that we set. And actually what we've been able to do this year is have a lot of conversations with the teams about how we can spend the money in the last quarter wisely to put us in a good position for next year, where things have been underspent or overspent. And that work's being done with the capital estates teams and finance. The red risk on the report is around the cath lab. Board will be aware that we moved this to be prioritised in the first quarter of next year's capital programme, and there's a paper on the confidential board to help us mitigate that risk even further for consideration. But the business case for that should be Q1, and we're well underway with progress on that. And the final thing to add is just around Mcgregor Award. One of our previous board workshops, we heard from the team about how the environment was really not helping them or supporting them to deal with the increase in children they were seeing with mental health illnesses and concerns. So the project is actually well underway. We've secured 100,000 this year from a national fund for these types of projects, and we've also already kickstarted the fundraising appeal on it and had 40,000 plus ready to launch the fundraising appeal wider. So that's hopefully demonstrating some progress on that important issue that we had discussed at board. I'm happy to take any questions.
Thank you, Sophie. Joking apart, the car park is fantastic, and Anne's putting the point about security of property as well being a big success. And for members of the public, in the confidential section, we're talking about our 10-year estate strategy plans, which Sophie has been leading the development of. Questions or perspectives on the capital update? So I assume the zebra crossing is now painted. Glenn's been out with the black and white paints, and we will have a zebra crossing by the time we get to Valentine's Day.
We'll have a temporary one because at the last minute we've received an objection, which we're working through with the planning consultants, but it won't stop us opening the car park because we were always going to put a temporary one in as we work with highways for them to complete the work that we need.
Right. And who's doing the official opening ceremony?
To be confirmed.
So if any celebrities, local celebrities who are watching this public board meeting, please get in touch with Sophie, and we'll try and sift through the celebrities who want to open up our car park for us. And I'd just like to put on record again the real sterling work of a number of our governors, including Roger Lloyd, who over the years have been big advocates of the car park. So thank you to governors for their part in pushing that project forward as well. Now we'll move then on to the learning from deaths, the 6 monthly update. Charles, what do you care to pull out of this report?
I believe that I'm going to take it on board.
Yeah, I actually have Pablo de Garcia, who wrote the report here today, so he would like the opportunity to tell the board about it.
That's great, Pablo.
Thank you, Chair. Thank you, Charles. So as probably you have read in the report, it's a quite reassuring mortality report, and as well, again, despite of the difficulty in meeting and having enough kind of mortality surveillance committee meetings, there is still a very good learning share across the trust of different topics and themes that have arise from the mortality reviews. One of the most significant themes to learn from is about advanced care planning and recognizing the dying process where the patients that get admitted to hospital and making early decisions about supportive care and kind of getting them into the right care instead of continuing in a bit of an excessive invasive procedure sometimes. In terms of numbers and statistics, the trust is in a very safe position. Our HIMR are still stable. We are in a, compared with national, we are in an expected level of mortality. There is three areas really, where the RAMI is slightly higher than expected or peers. That is all general surgical deaths, AKI, acute kidney injury, and COPD. For the all surgical deaths, Mrs. Anderson already conducted a very comprehensive mortality review and concluded and satisfied the Mortality Surveillance Committee that there was no particular care deficiency to be recognized in the high mortality, and that the high mortality rates in surgery come from the emergency admissions of a quite frail and elderly population with a lot of comorbidities. Hence, we have higher mortality rate because we have a more elder and more comorbid population. For the COPD deaths and the RAMI and the COPD deaths, that has been kind of higher above peer for a few months now. We have commissioned, the Mortality Surveillance Committee has commissioned a review of those deaths that is undergoing by the respiratory team and should be ready before the quarter ends, hopefully, and reported to the Mortality Surveillance and then the Clinical Governance Committee. And for the acute kidney injury, very recently, the deteriorating patient group has as well commissioned 2 clinical fellows to be the champions and the advocates in the trust for AKI improvement and bundle completion. And as well, very recently, we appointed a consultant in acute medicine department that is both acute physician and renal physician, and she is about to embark a 6-month project to develop strategies alongside with Coventry Hospital to improve the management of the acute kidney injuries within the trust. So hopefully we should see that RAMI of the acute kidney injury going lower in the next 6 months for the next report, really. Apart from that, the position compared with the other 2 trusts of the group is a good position. We are within the same kind of trends, and as well our mortality in the CUSUM graphs are going back down to the lower 2 sigma line, which is a very kind of reassuring and very safe level. And that's really a bit summary. I mean, the medical examiner role is growing and is expanding and is now getting all the national, and applying all the national guidance as it should, with expanding into the community and starting projects for the community. And so I will say that, we are.
Thanks, Pablo.
We're okay.
Pablo, thank you. Really comprehensive and clear summary. And thanks for your hard work on this, and the stats in the report are very helpful. Any questions or perspectives to Pablo or Charles? Please raise a digital hand. Lots of positive comments, Pablo, in the chat box. I'm not sure whether you can see those. Okay,
yeah, thank you.
Yeah, no, thank you, and continues to keep us briefed, and we look forward to seeing you next time. So I think then we're on to the CQC update, including the insights report. Fiona?
Yes, I've not got much to pull out of here. I think it's a fairly self-explanatory report in terms of our performance. The areas of decline are not a surprise to us given the current pressure and what I've already reported on, but actually it's amazing to see most indicators have actually improved, so it's an improving position despite the pressures, so congratulations to all the teams.
Okay, thank you, Fiona. Any questions or perspectives, Fiona, on the insights report? Okay, we'll move on then to the Audit Committee report for the 8th of December. Anything you'd like to add, Rosemary?
No, just like to highlight that all the internal audit reports that we looked at all gave significant assurance, so that gives us ongoing ongoing assurance of the general systems in place at the trust. The one point I just wanted to highlight was regarding information governance and cyber security. The trust earlier in last year had into an external review of compliance with the Cyber Essentials Plus accreditation. The trust failed to meet the requirements of Cyber Essentials Plus as was anticipated, and work is now underway to try to close that gap, including the appointment of 3 new cybersecurity specialists to help us to continue to monitor cybersecurity risks. Those obviously will be appointed by Innovate. This does though mean that we're not going to be in position this year to have a clean sign off on the data security protection toolkit, because bar has been raised again, and it's a requirement to meet Cyber Essentials Plus. So I think overall, whilst SWFT, compared to most NHS trusts, is in a better position regarding cyber security, we need to be very alert to the fact that cybersecurity remains and currently is probably a growing threat to organisations, and we remain at risk here despite the continued investment.
Thank you, Rosemary. Very clear, and we'll obviously need to hear that level of risk. We'll come on to the board assurance framework and risk quarterly report in a minute. Any questions to Rosemary? Thank you, Rosemary, for your diligence, and everyone on the audit committee and the clinical governance committee for the 8th of December and 12th of January. David, what would you like to put out?
I don't think I need to add anything to what's in the reports. I mean, the only thing I would make clear to everybody that our January meeting was considerably abridged because of the COVID-19 situation. So we didn't actually receive any written formal reports at that meeting, but we did get verbal reports.
Okay, great. And any questions or perspectives to David? No, the point I was going to make was I do just want to recognise the fact that in terms of non-execs, we are well down in terms of our number of non-execs at the moment, since we've lost Jeff, Ben and Chris Lewington. So I just want to thank my non-execs for their hard work and diligence in making sure we're always quiet at these subcommittees. It's greatly appreciated. So we'll move on then to the board assurance framework and risk quarterly report. Anne, what would you care to pull out of this?
Yeah, this is part of our cycle of quarterly assurance to the board. This report doesn't highlight any particular concerns, but it does flag our highest current risks, including the financial challenge faced by the trust and other organisations in the local health economy. So it's there for information. Happy to take any questions.
Thanks, Anne. And again, apologies if this has already been mentioned, but we did have a session as a board on risk appetite this morning, which will obviously feed into the future of this report as well. Any questions or perspectives on the BAF or the risk quarterly report? Rosemary? Rosemary, you're on mute.
Right, that's better now. Following on from my earlier comments from the audit committee, it struck me that there is no reference anywhere in this paper to the cybersecurity risks. And it's hard for me as a NED to see where that has been considered. Obviously, only the highest risks come forward, but it is a high risk. And I just think we need to continue to be considering cyber risks. I'm thinking, I don't know whether it's there with the other foundation trusts, but I would expect to see reference to cyber risks.
Yeah, I agree. Anne?
Yes, and you will, Rosemary. We have, just as part of our refresh of the risk management strategy, looked at the infrastructure around the implementation. So that has led us to review and undertake a recasting of the corporate risk group. So it will be there that we will hold those, the cyber risk and system place risks. So that was an outcome from our discussion at board workshop a few months ago. So you should expect to see that that coming through, because you're right, we were holding these risks in different parts of our organisation, and now with the refresh of corporate, it will become much more visible.
Excellent.
Thank you. Any other questions? Colleagues, happy to move on. Okay, so we move on then to the summary of ratified policies.
And again, the board is asked to receive and note the summary of the following ratified policies: the corporate records policy and the development and control of the trust's documents procedure. They were ratified at Policy Review Group on the 17th of December.
Yep. Any questions or perspectives? Rosemary, I assume that's a legacy hand. Okay, thank you, Anne. And the summary of reports for noting and information. Anne, did you just want this noted?
Yes, yes, it's the Registration Authority's annual report.
Yeah. Any questions or perspectives from colleagues? Okay, then we've got the updated Register of Directors and Register of Directors' Interests.
Thanks, Russell. So this is just to formally receive a note. It's due to recent changes around Bruce Paxton. His term of office has ended. The changes to Harkamau due to Stephen Coleman's resignation, and they're highlighted in bold on both registers.
Thank you. Any questions from colleagues? I'd just like to make a general point on this, because I notice when I see and review this in other organisations that I'm aware that some directors don't declare everything. I expect my directors to declare everything, even if it's quite a small involvement with an organisation. If it's a formal involvement, I expect you to declare it, and I'm sure you all do. But I'm just conscious in other places that doesn't always happen, which surprises me. So I just wanted to make that clear as chair of the board. Now we'll therefore move on to the board committee minutes. The audit committee of the 13th of October. Seems a long time ago, Rosemary. This is just for receiving. Any points? Colleagues happy to receive? Thank you. And then the clinical governance of the 10th of November and 8th of December. David, anything you want to add? Any questions from colleagues? Please raise a digital hand. Okay, so I think we're then on to any other business. Please raise a digital hand if you've got any other business. Okay, just me again apologising for not being with you at the start of the meeting. I think we've had some questions from governors and members of the public. Do you want to read those out first, please, Sarah?
Thanks, Russell. So we've had 3 from Roger Lloyd. I'm going to take them individually. So the first one is, whilst the 28 cancer target and the 31-day diagnosis to treatment cases are below the target values, is the direction of travel acceptable and consistent with an upward trend? And how does the trust performance rate in our system? I think Anne Coyle was going to take this one in the absence of Harkamau.
So if I may, I think we've covered off as part of the earlier discussion the 28-day faster diagnosis standard. So looking at the 31-day diagnostic to treatment, then performance against that standard has been more variable in terms of delivery. Although, having said that, we've seen an upward trend since July 21 with December meeting the standard, and our forecasting is that January will also meet the 31-day diagnostic to treatment standard. The challenge we faced is COVID has placed delays in treatment pathways, either due to additional testing for patients pre-op or pre-chemo, or we're seeing a reduction in capacity, so that we remain compliant on our green pathways, so ultimately protecting our patients, and we are continuing to maintain those. So it's variable. There is reason that to acknowledge there is improvement, and we are maintaining that that consistently. But it is against a backdrop of where we're delivering more treatments than ever, and putting us in one of actually the fastest recovering cancer services in the West Midlands. So putting it within that context, it is an upward trend, and sharing how we rate in our system, in the West Midlands system, against that target.
Super, thank you. And then the second question, Sarah.
Thank you. Is the Chief Medical Officer content with the state of the pathology turnaround times? Charles.
Yes. The short answer is yes, there's been considerable improvement. And I think we're talking about cellular pathology, i.e. histopathology here. There was some problem with maintaining staff in the laboratory, but that has improved, and the turnaround times from the latest figures are now within the standard, apart from one very small area that isn't. And it should be noted that it's histopathologists employed by SWFT who do this work, although the lab is within the pathology network.
Thank you, Charles. And the third question, Sarah.
Thank you. So with the cost and productivity improvement plan appearing to be far below the required values, does the Chief Finance Officer have plans in place to mitigate for the absences of CPIPs to achieve a surplus in 21-22?
Okay, thank you. So I think we did cover this off partially in the way Glenn explained the way we're putting things in different buckets. But Kim, is there anything else you'd like to add from what was said earlier?
No, just to reassure the board and the public that you know, it is a presentation thing. So we have got schemes underway to ensure that we do deliver a break even, if not surplus, at the end of this financial year.
Thank you, Kim. And we've got a couple of minutes left. Would there be any other questions from members of the public? Please raise a digital hand. Okay, I can't see any digital hands being raised. Just like to thank members of the public for joining us again, and look forward to seeing you at the next board meeting, which is on the, trying to find desperately the date, the 2nd of March. So in the meantime, take care. Please continue to socially distance. The fact that we have dropped the Plan B requirements doesn't mean we need to be totally laissez-faire in the way we look after one another. So thank you all very much. To board colleagues, I suggest we get going again in 10 minutes at 3:40 in the confidential section. Thank you very much.